And I have great pleasure in meeting Duncan Smyth this morning, and now I get the chance to introduce him. So Dr. Smyth is a Wellington-based neurologist, but don't hold that against him. He has a strong clinical and research background in peripheral nerve disorders. He completed a fellowship in peripheral nerve disease at the Distinguished National Hospital for Neurology and Neurosurgery in London, where he focused on conditions caused by inflammation, blood disorders, drugs and toxins. He was also awarded a prestigious Chapman Fellowship, which supported his research into chemotherapy-induced peripheral neuropathy at University College London. Today, Dr. Smyth will be sharing his insights on amyloidosis navigating the new frontier, a timely and critical topic in neurology that affects both patients and practitioners alike. Please join me in welcoming Dr. Duncan Smyth to the stage.
Good morning. So yes, I'm Duncan Smyth. I'm a Wellington hospital neurologist. Very pleased to be here. So I'm going to be mainly talking about the ATTR amyloidosis polyneuropathy. So I thought I'd just give a little bit of a background on peripheral nerves and peripheral neuropathy, because before I went to medical school I didn't really have what a concept of what a nerve is. So nerves, basically peripheral nerves, are cord-like structures throughout the body, but particularly in the arms and legs, and they connect with the central nervous system, which is the brain and spinal cord. So they deliver information from the central nervous system and back to the central nervous system. So if you can imagine a nerve a bit like a telephone wire, and within that you've got lots of tiny little wires, and so these are the nerve fibers or axons, and then there's lots and lots of axons within each peripheral nerve. And some of these axons are surrounded by myelin, which is a sort of fatty sheath that helps the nerves conduct more quickly. And there are three types of axons or nerve fibers. There are motor fibers, which connect to muscles, and so they control muscle movement. There are sensory nerve fibers, which provide sensory information from the skin back to the central nervous system. And then there's autonomic nerve fibers. And so these are a bit like the housekeeping nerves of the body. So they connect to the blood vessels and the heart and the gut and various other organs, and basically regulate their function. So as I said, within each nerve there's going to be a combination of lots of different small nerve fibers, and so some of these nerve fibers are large and they're surrounded by myelin, and these are the motor nerve fibers, and the sensory nerve fibers, which are involved in proprioception, which is like the recognition of where our joint is in space, so sort of how we can sort of feel where we are in space, so that's important in balance. And then there are small nerve fibers, some of which are and some of which aren't surrounded by myelin. And so these small nerve fibers, these are involved in the recognition of pain and temperature sensations, so whether we can feel hot and cold and pain. And I mention this because these are often involved preferentially initially in amyloid neuropathy. So peripheral neuropathy is also called polyneuropathy. It's the sort of an interchangeable term. So what this is just damage to peripheral nerves, okay? And so there's a lot of different causes to this. So the most common cause is diabetes, alcohol, some chemotherapy drugs, nutritional deficiencies, and genetic causes are the most common causes. But in up to 30 to 50% of cases, it's said to be idiopathic, which is we can't find a defined cause. And so whether it's 30 or 50% probably depends on how hard you look. But peripheral neuropathy is quite a common thing. Probably at 70, there's about 5% of people will have some degree of peripheral neuropathy. Most peripheral neuropathies involve damage to the axon, so those are those wires in the nerve. That's called an axonal neuropathy, with a smaller percentage involving damage to the myelin. And most peripheral neuropathies are what we call length dependent, which means that they involve the nerves furthest from the body, the longest nerves. So they start in the feet and they work their way up, and once you get to the knees it might involve the hands and the upper limbs as well. Most neuropathies are sensory predominant, so they don't involve too much weakness. They progress very slowly, and most don't lead to significant disability, particularly idiopathic neuropathy. Most of the time, will cause some numbness, might be a bit annoying, but it doesn't lead to significant disability. But certainly there are a number of exceptions for particular causes, and amyloid is one of those. So with amyloid peripheral neuropathy, you get the amyloid fibers deposited in peripheral nerves, and obviously also deposited in other organs. So both AL amyloidosis and TTR amyloidosis can cause peripheral neuropathy. The AA amyloidosis we heard about doesn't cause peripheral neuropathy. So amyloid neuropathy involves all types of nerve fibres. And AL amyloidosis and some forms of hereditary TTR amyloids, this is I'm going to call ATTRv, V standing for variant, commonly cause neuropathy, whereas wild-type TTR less commonly causes neuropathy, but it can. And so I mean, we've heard a lot about the pathophysiology from Tim earlier, and so I don't have to repeat all of that, but essentially the liver is the main source of TTR in the body, and TTR, transthyretin, it usually is in the groups of 4, the tetramers, and the real rate-limiting step is where it dissociates into just monomers, so just single TTR, and then they can become abnormally folded and then form amyloid fibrils and deposit in the nerves in the heart and other organs. So we see a lot of peripheral neuropathy in our clinics. And what we're looking for, I guess, is we're always sort of on the hunt to see what would indicate a more serious cause, something that requires a specific treatment. And so with amyloid neuropathy, that's obviously one of the more serious causes where there are treatments, and so it's important we're able to recognise that. So when we're looking at TTR peripheral neuropathy, there's early onset and late onset. Early onset is defined by less than 50 years and late onset of over 50 years. And whether it's early or late onset will depend on the particular sort of mutation someone has, and also even within that same mutation, the part of the world they're from. So people with the V30M mutation in Portugal, it's usually early onset, but in Sweden it's usually later onset. Like most neuropathies, amyloid neuropathy is usually symmetrical, so same on both sides and length dependent, starting at the feet and coming up. Now the neuropathy often starts with involvement of those small fibres, so that's loss of pain and temperature sensation on examination, and small fibre neuropathies are often intensely painful, so that's sort of a burning pain, often when people are at rest, often at night. It can affect sleep. And so a painful neuropathy is a red flag for amyloid, both TTR and AL amyloid as a cause. So eventually people are going to develop weakness, loss of the balance, loss of the proprioception, loss of reflexes, but at onset, at times, it will just be the small fibres, and so all of those other signs may come later. And this is important because the main test we do to diagnose peripheral neuropathy is nerve conduction studies, and nerve conduction studies only measure the large fibres, and so you could actually, if you present early on with just a small fibre neuropathy, you'll have nerve conduction studies and they'll be completely normal, so then you've just got your clinical examination and history to go on. The later onset TTR neuropathies tend to have less pain, and they can present with the large and small fibre neuropathy sort of at the same time, whereas the early onset it's more the sort of small fibre initially. But certainly with AL amyloidosis as well, often very painful. It's often more rapidly progressive and severe than most neuropathies, and so people will develop loss of balance, weakness, and involvement of their upper limbs. But there's also other signs outside the peripheral nerve, so weight loss. There's obviously a family history in TTR neuropathy in a lot of cases, and there's usually prominent involvement of the autonomic nervous system, and I'll show you a slide on this specifically. But the most common cause of autonomic neuropathy by far is diabetes. But if someone doesn't have diabetes and they've got a neuropathy with significant autonomic involvement, then that really is a red flag for amyloid. And then there's evidence of other organ involvement, which I'll go through as well. So autonomic neuropathy, autonomic symptoms can be really disabling. One of the cardinal symptoms is postural or orthostatic hypotension, and that's basically when you stand up, your blood pressure drops and you might feel faint, or you might actually fall over and faint, and that's really disabling because people sort of unable to get up because of these horrible symptoms, or they might fall over. And this is because the nerves that are controlling the heart and nerves controlling the blood vessels are damaged. So usually when you stand up, your blood's pulls down in your legs, your blood pressure might drop. But what most people will do is they'll squeeze the blood vessels, okay, and that will increase the blood to the the central part of the body, and they can increase their heart rate and how fast the heart, how hard the heart pumps as well, to keep the blood pressure up. But if those nerves aren't working, then the blood pressure will drop and people can faint. There's bladder and bowel dysfunction, so you can get both sort of a slow, low-flow bladder and an overactive bladder with urgency and incontinence, and sometimes both. And same with gastrointestinal dysfunction. People can get constipation, and they can get diarrhea as well. And the diarrhea is often high volume and nocturnal, so prominent at night. And people can also have sort of an early fullness after eating. Erectile dysfunction is very, very common in all autonomic neuropathies in men, and there can also be impairment of sweating. So people might find that the sweat glands in their legs are impaired. So when they get hot, their lower legs don't sweat, but the upper body might sweat excessively, and this can cause problems with regulation of temperature. So other organ involvement's really, really important, and I think I'm going to highlight the top two: carpal tunnel syndrome and cardiac. Now, these are really, really easy to ignore because they're both incredibly common problems, and usually it's sort of ignored and thought to be a coincidence, but actually it could be a coincidence, but they might be a vital clue. So carpal tunnel syndrome, what happens is you've got the median nerve at the front of the wrist. It's in a sort of a small tunnel. And sort of often, with occupations, if someone's using their hands a lot, things like knitting or, being a builder or something like that, you can get swelling, and that causes irritation and compression of the nerve because it's in this tight tunnel. With amyloid, you get deposition of amyloid in this piece of tissue that sits on top of the tunnel. So when somebody's, younger and they have carpal tunnel syndrome, it's often sort of in their dominant hand because they're using the hand more than the other. With amyloid, it's often bilateral, and it can be very severe, and it may precede neuropathy by up to about 10 years. Okay, so that can be sort of a clue that something is going to happen. But it's a really common problem generally. So it is something that's often ignored. So that is one clue, and cardiac disease as well. So we know heart problems are just really common as people get older. So people might have cardiac type symptoms. They might have a history of heart rhythm abnormalities like atrial fibrillation, really common. But that might be the clue, or they might have restrictive cardiomyopathy, which is a little bit more specific for amyloid. Deposition of amyloid in the bowel can contribute to weight loss and diarrhea. Kidney involvement, so people can get protein in the urine, and kidney failure. And we've heard about spinal stenosis, where this ligamentum flavum at the back of the spine has amyloid deposition in it, and then the nerves at the base of the spine get compressed as they go through the spinal canal, and this can lead to back pain and intermittent claudication, which means when you're walking you have to stop because your lower legs get numb and painful. It can sometimes involve muscles and the central nervous system as well, because there is some TTR is produced in the choroid plexus as well, and so the amyloid can then get deposited in the meninges, which are the coverings of the brain and the brain arteries. And the most serious complication of that is intracerebral hemorrhage, so bleeding in the brain. It can also cause transient stroke-like episodes where people might get numbness on one side or weakness on one side, lasting half an hour and then resolving. And seizures as well, and it's often associated with something that occurs after liver transplantation. And then there's multiple ocular or eye manifestations because TTR is also produced in the eye. So why is it important to diagnose TTR amyloidosis? So there's a number of reasons. I think firstly, most people want to know what they have, and that gives, prognostic information. So you know what you have, you can plan, and then you can, get the treatment you need for any symptoms as they come up. And obviously, it's now a treatment. There's it's now a treatable condition, and there are clinical trials available, which is particularly important in New Zealand, where we don't have all the treatments that we would want. So, I mean, I think that's probably the most important reason why it's important to diagnose early, because people are going to be more responsive to treatment earlier on. And it can be used to help family or whānau members with hereditary TTR amyloid. So it's autosomal dominant, meaning that somebody's children have 50% chance of inheriting the condition, and so siblings and children can obviously be affected. But if you could diagnose people earlier or pre-symptomatically, then they might be able to access treatment earlier, and then obviously that's much more favourable. And then there's the potential for pre-implantation genetic diagnosis, where you can select an embryo without the mutation to avoid passing it on to the next generation. And then the other thing, and this is important with AL amyloid as well, is that also for hereditary amyloid, in some mutations, it presents predominantly with a neuropathy, but if you leave it long enough, people are going to get cardiomyopathy. And neuropathy has a huge impact on quality of life, but cardiomyopathy is probably more of a risk to life. So actually diagnosing the neuropathy can allow people to get the treatment they need earlier, and that's certainly the case with AL amyloidosis. Usually neuropathy is present before people develop cardiomyopathy later. So talking about diagnosis, so when we're faced with people in the clinic, we're usually faced with someone who has a question of peripheral neuropathy. So on our history and examination, it's usually reasonably straightforward for us to determine whether they've got a neuropathy. And so in the clinic, I will usually do a lying and standing blood pressure, particularly when there's a suspicion for something like amyloidosis, or when there are symptoms suggestive of autonomic dysfunction. So we'll take the blood pressure lying down, then standing up, and then after standing up for 2 and 5 minutes, because it can take a couple of minutes for the blood pressure to drop off, and if it drops off by more than 20 points, then that's suggestive of autonomic dysfunction. I mean, that can happen sometimes if you're on blood pressure lowering medication, but if you're not, certainly that could indicate autonomic dysfunction. Nerve conduction studies are pictured up there. So nerve conduction studies, we're providing a small electrical pulses or electrical shocks. We call them pulses because it sounds less bad, but to the muscles and the skin to essentially, or to the nerves, and measuring the responses of the muscles and the skin to see how well the nerves are working. Now, just to caveat that only measures the large fibres, so early small fibre neuropathy, it might be normal, but eventually it's going to become abnormal, and that's going to allow us to diagnose that you've got a neuropathy affecting large fibres. Is it axonal or demyelinating? So is it mainly involving the axons or the myelin sheath? In amyloidosis, it's an axonal neuropathy, but in some cases it can look like a demyelinating neuropathy, which is where the nerves conduct very slowly. And that can sort of confuse people and lead to incorrect diagnosis, but usually it's going to look like an axonal problem, and then and we're going to be able to say how severe it is. And then autonomic function testing. So the access to this is a little bit variable. I'll talk a bit about that on the next slide. And then of course excluding other causes. So we've really got to look for the common causes. Got to make sure people aren't on medications that can cause neuropathy, that they're not drinking 2 litres of vodka a day, they don't have diabetes, kidney failure, all these other things. But particularly, and we've heard this from Tim too, looking very, very carefully for a paraprotein. Okay, so that's looking for serum and urine electrophoresis and immunofixation. So immunofixation is where you see these very small paraproteins, and very, very small paraproteins can still cause significant neurological problems, and the serum-free light chains. So the next step is to do TTR genetic testing, just the blood test, and then the final step is to, depending on the person, either a tissue biopsy or a cardiac bone scintigraphy scan. So this is called tilt table testing. So this is part of the autonomic function testing. So they can do some other physiologic measurements as well, things like heart rate variability. And in some countries they can do sweat gland testing. I'm not aware we're able to do that here, but this is a tilt table test, and this provides a bit more stress on the body than just sort of standing up. And so somebody's tilted to 60 or 70 degrees, and the blood pressure and the heart rate are monitored. And so in this person, after they've been tilted up 60 degrees, the blood pressure drops right off, and they might feel dizzy or even pass out. And so what should happen is that heart rate should go up, so the blood pressure stays the same. But in this person, because they've got autonomic neuropathy, the heart rate can't respond in that normal way, and so the blood pressure drops. And so that can be helpful to make a diagnosis of an autonomic neuropathy. And so this is a paper from an Australian colleague, and I mean this just sort of goes through the process from a neurologist point of view at making the diagnosis. But after you've got your positive TTR gene test, where you might go next depends on whether or not there's a family history. If there's no family history, you would go for a tissue biopsy. If there is a family history, then you could do a cardiac bone scintigraphy scan, and if there is grade 2 or 3 uptake, so if there's significant heart involvement and you meet some other criteria, you may not need to do a biopsy. So the tissue biopsy is important. So you're looking for amyloid deposits in tissue, and I guess the reason to do that is, people can have a mutation and then they may not have actually developed the disease yet because it starts later, or because of something called incomplete penetrance, somebody might not actually develop the disease. So it's trying to prove that the neuropathy or the symptoms are due to amyloid. You can biopsy the heart, as we've heard. You can biopsy the sural nerve, one of the sensory nerves in the leg. It's often easier and with less complications to get a minimally invasive biopsy called an off-target biopsy. And so, there are various things you can biopsy: the skin in the lower leg, the abdominal fat pad, the salivary gland in the lip. I don't think rectal biopsies are done quite as much these days. I don't know about the sensitivity. These might be a little bit generous. So they're not 100% sensitive. You might have to go back and do other biopsies. Nerve biopsies probably a little bit better. And then obviously cardiac biopsy is very sensitive for heart involvement, but comes with risk. So you're looking for this, this pink stuff here is amyloid, and then looking green under the polarized light. And actually, this isn't available in New Zealand or I think in Australia as far as I'm aware. This is looking at what's called intraepithelial nerve fiber density, which is looking at the number of small nerve fibers in the skin. And if you biopsy the skin in the lower leg, you can sort of count up the number of small fibers in the skin. These arrows are, are pointing to them. And so if somebody has a small fiber neuropathy, they've got a reduced number. And so if you were going to do a lower leg skin biopsy, in some countries you could do that at the same time, but it's not, it's even when I worked in the UK, that wasn't widely available. And then trying to type the amyloid fibrils, so to determine whether you've got AL or TTR amyloid, so immunohistochemistry, which is the older technique, which is where you take the biopsy slides and you put antibodies onto them to try to determine whether it's TTR or light chain. And so in this example, brown is positive, so this is to an anti-transthyretin antibody. It would sort of light up in brown, and then the light chain antibodies were negative. But it's not 100% sensitive, it's operator dependent, and then mass spectrometry is more sensitive, and one study was shown to, it was able to make a diagnosis in 80% of the cases where immunohistochemistry was uncertain. And not to go through this too much, but essentially what they do is they digest and dissect a biopsy sample, and it goes into the mass spectrometer, which measures the ratio of the mass to the charge, and it goes into a bioinformatics machine, and it can tell you what particular protein it is. So then the cardiac scintigraphy scans, I'm going to hopefully not embarrass myself with this, but this is essentially showing, from no heart uptake of one of these traces, DPD or PYP, and then going up to sort of grade 2, where it's about the same as the surrounding bones, and grade 3, where it's greater than the surrounding bones. And this is a very sensitive and specific test. And so if somebody has a family history, they have either grade 2 or 3 uptake of on the bones on the scintigraphy scan. If they have some other imaging features suggestive of amyloidosis and no paraprotein, you may not need to do a biopsy. But this test is also important to I guess stage the disease. So how much organ involvement, does your disease involve the heart? We've seen some various variations of this diagram here, and so this is really just looking at the different mutations in hereditary amyloidosis, and that some of them predominantly present with neuropathy, like V30M early onset. Some of them predominantly present with a heart problem, wild type, and V122I, which is the one that's common in Afro-Caribbean people, and then some are a bit more mixed. I did actually have a slide which I got rid of on sort of the prevalence sort of worldwide of TTR peripheral neuropathy. There was one study on this, and I think they said it was around about sort of 5,000 or 6,000 people worldwide. So which is about sort of 1 in a million, which to me seems an underestimate. This is of polyneuropathy and TTR, so that did seem quite low, which was around about 1 in a million. When we're looking at how common peripheral neuropathy is when in TTR, so cardiomyopathy due to TTR cardiomyopathy is more common overall because wild type, the aging problem is more common. So the majority of patients with TTR amyloid are going to be presenting mainly with cardiomyopathy, but with hereditary TTR neuropathy is more common because the most common worldwide mutation is a V30M, which is predominantly going to present with neuropathy. But they have studied some of the more cardiac type mutations, so like V122I, which is predominantly a cardiomyopathy, and more than half of them had neuropathic symptoms. They didn't do nerve conduction studies, so it's a little bit hard to know whether some of that could be spinal stenosis or carpal tunnel syndrome. But I think it indicated that even if those of those types of hereditary amyloid, there was significant numbers having neuropathy symptoms, then probably the majority of people will have some neuropathy. But whether it's just sort of a minor thing, a small symptom, or whether it's the major manifestation of their disease depends on the particular mutation. And so current treatment options. So I'm going to talk about disease-modifying treatments and also the sort of general supportive care, which is important as well. And so, these are the things that more available in New Zealand in red. So liver transplantation. So you're essentially getting rid of the main source of the mutated TTR protein, and so you replace it with the wild type TTR. And so in series, about 75% of people survived at 10 years. This was in people with early onset TTR caused by V30M mutation. A few people improved, but the majority of people, it was more of a stabilisation, slowing of their neuropathy. But in the later onset, there was a significantly lower survival at 10 years than the early onset, and so it may not be effective in that group. Some of the problems is that we know that TTR is produced in the eye and produced in the choroid plexus of the brain as well, and so sometimes this can even accelerate after the liver transplant, and so then people can present with later with really troublesome problems, in terms of amyloid in the eye and amyloid in the brain as well. It's obviously a significant procedure to go through. There's a lot of potential complications, and people need to be on immunosuppressive treatment long term. And then there is also this phenomenon where people start depositing the wild type TTR in the heart, and so up to about 20% of people will develop a cardiomyopathy after the transplant, which is a lot higher than the rate of cardiomyopathy if you're getting a liver transplant for another liver disease. And so it's no longer recommended for TTR cardiomyopathy, but could be an option in people with peripheral neuropathy in whom other treatments are either not available, not suitable, or not effective. Doxycycline I'm going to mention here because we can prescribe it here, but it's a commonly used antibiotic. Might use it for chest infections. People use it for acne, anti-malarial prophylaxis. So if you go over to the Pacific or India or something, you could take doxycycline. In the lab, it's been shown to disaggregate amyloid fibrils, and so there was this small open label study just over 10 years ago. So open label meaning it wasn't compared to a control group or a placebo. So this was doxycycline in combination with TUDCA. I'm not going to attempt to pronounce the whole word, but TUDCA, which is a bile acid produced in the liver, and that reduces the aggregation of TTR. And so it was thought that these two, chemicals would work together to reduce aggregation of TTR. And so there was these 20 patients were given these two treatments for 12 months, so various forms of hereditary TTR and or wild type. Only 7 of them were still on treatment at 12 months. Of those 7, the 6 with neuropathy, 5 were either stable or better, and 1 was worse. And with all the people with cardiomyopathy, all remained clinically stable, but it wasn't compared to a control group. So I think there's really not evidence to recommend this at the moment. Has been a phase 3 randomised study completed, but from what I could see, there weren't any results completed, so watch that space. And then clinical trials, I won't talk too much about that, but obviously clinical trials, like the CRISPR-Cas9 trial, are important, particularly in New Zealand, because we don't necessarily have access to the other treatments. And so just to talk about some of the other treatments, so TTR stabilisers. So as we know, the rate limiting step for development of TTR amyloidosis is where these groups of 4, the tetramers of TTR, they dissociate into just groups of 1. And so what these drugs do is they sort of bind to the thyroxine binding sites, and they stabilise the tetrameric structure, and so they prevent that dissociation into monomers. And so the 2 examples of that are diflunisal and tafamidis. So diflunisal is an older anti-inflammatory drug, so like ibuprofen, aspirin, Voltaren, and those sorts of drugs, initially developed to treat pain, and I think it was MedSafe approved here for many years, but then it lapsed because people weren't using it because there were other treatments. But now it's been shown to stabilise TTR, and so it's being repurposed for treatment of TTR amyloid. So there has been a randomised study in neuropathy on this back in 2013, comparing diflunisal versus placebo for 2 years. And so there's a thing called a neuropathy impairment score. Basically, the higher the score, the worse your neuropathy is. And so over that period of time, that increased by 25 points with the placebo and 8.7 points with the diflunisal. So people did continue to get worse, but much less on average than with the placebo. There was improvement in quality of life measures, and people were more likely to remain stable if treated with the diflunisal. So it has been used off-label, and there has been an initial recent marketing authorisation from the EMA for use in stage 1 and 2 polyneuropathy. And tafamidis is obviously much more expensive, and this has been used is used on a much more sort of regular basis than sort of the ad hoc way diflunisal's been used. The first study looking at this was with people with the V30M mutation, and the way they they used this neuropathy impairment score as well. And then the way they defined the response rate, 60% of people seem to respond as per their definition, to the treatment compared to 38% of the placebo, and the quality of life deterioration was reduced. And there have been subsequently some other studies as well, that there's a sustained delay in neuropathy progression for at least 5 years, and also improved survival compared with untreated patients. But it's not as effective if people have more advanced neuropathy, so it's much better to treat people with early stage disease, and of course it's now been shown to be effective in cardiomyopathy as well. And acoramidis we've heard about, approved for cardiomyopathy, not yet studied in neuropathy. Gene therapies, so patisiran, the study came out in 2018, so this is an intravenous treatment which is used around the world. So patisiran is what's called a small interfering RNA, so it's a piece of RNA which is a bit like DNA, but a small piece of genetic material, and it's covered in this sort of fatty lipid coating which helps it get into liver cells, and what it does is it breaks the TTR messenger RNA to reduce the production of the TTR protein. And so it reduces blood levels of TTR by more than 80%, and in the original randomised study, so this is the neuropathy impairment score again. Going up means worse, and going down means getting better, and the placebo group, people got worse, and with patisiran, people were either stable or got better. About 50% of people actually showed some sort of improvement, and same for their quality of life score as well. And then valtisiran is a subcutaneous injection, so a lot easier to give. Also showed pretty similar results, people getting worse with placebo and remaining pretty stable with the treatment. I'm going to mention eplontersen as well. So this is what's called an antisense oligonucleotide, so a short piece of genetic material. So this is given by subcutaneous injection, and what this does is it binds to and inactivates the TTR messenger RNA. So there was a drug called inotersen, which has been approved and clearly did work. The problem was that there were some cases of people with low platelet counts in the blood and having bleeding or getting kidney inflammation, and it wasn't being used as much, so I think the company decided to discontinue this. But now inotersen has been attached to a compound which optimises the delivery to the liver cells, which reduces the chance of those side effects. And so this reduced serum TTR levels again by about 80%. And comparing in the study, comparing it to a historical placebo group, neuropathy impairment score worse with placebo, stable with eplontersen. And so general management I just want to talk about. I think physiotherapy exercise is really, really important and beneficial. I'm going to talk just particularly about two things: neuropathic pain and autonomic neuropathy, because these are some of the most disabling symptoms. So neuropathic pain, I think using both a pharmacologic medication and non-medication approach, a combination of the two is best. So there are various types of medications, so tricyclic agents like nortriptyline or amitriptyline, gabapentin or pregabalin, and venlafaxine. These all have evidence to show that they can reduce that neuropathic pain. And if sometimes people have side effects to those medications, or they would desire not taking another tablet, there are topical treatments. Capsaicin cream, which is like a chili cream, might be helpful. These lignocaine patches. And I think non-pharmacologic approaches are helpful. The TENS machines, so the trans-electrical neurostimulator machines, some people find helpful, some people find them painful, but some people do find them helpful. Exercise is really important, both in terms of your sort of brain response to the pain, how you're going to manage the pain, but also, it probably has a physiological beneficial effect on nerves as well. And I think pain clinics, so if you've got access to them, chronic pain services are quite helpful, because they have access to other professionals as well, physiotherapists, psychologists, who can really help improve people's pain. And in refractory cases, they've also got access to some sort of more heavy-duty treatments if this is needed. And then the autonomic neuropathy. So these, as I said, are really disabling symptoms. So for the orthostatic hypotension, now, it's a combination of different things. Now, if you've got heart failure as well, you're probably not going to be wanting to have heaps and heaps of fluid and salt, but if you don't, then you could certainly should be having a good fluid intake, have a fair bit of salt so that maintains your blood pressure when you stand up. But there's other things you can do dietary-wise, eating a potassium-rich diet, so that's lots of bananas and kiwi fruit, caffeine as well, and simple things as well. So if you're in a situation where you are likely to develop symptoms, so if you've been lying down for a long time or sitting after a large meal, for example, you could either have a large sort of pint glass of cold water, can help increase the blood pressure, or perform 20 calf raises. I mean, as I said, exercise is helpful. Other things you can do, waist-high compression stockings, even raising the head of the bed by about 10 or 15 centimetres can be quite helpful, and that can reduce the sort of high blood pressure people get at night and reduce the impact of the low blood pressure when you stand up during the day. And it's important, of course, to make sure you're not on medications that are going to drop your blood pressure too much, but there are medications you can use to increase the blood pressure if that's needed. Gastrointestinal symptoms, once again, combination of pharmacological and non-pharmacological things. If slowness is the problem, it might just be a matter of keeping a good fluid intake or having some fibre or bran, but you might need laxatives. You might need medication for diarrhoea, and sometimes both can be a problem. And with the urination, if overactive bladder is a problem, it might be a matter of toileting schedules, making sure that you toilet regularly, and pelvic floor exercises, or medications might be needed. And if urinary retention is the problem, something called the Creed manoeuvre, which is where you sort of put pressure on the bladder, and sometimes people need to do intermittent self-catheterisation, and not to forget erectile dysfunction as well. Yeah, so that's all I've got, so happy to take any questions.
My impression is that often in people with amyloidosis, they have peripheral neuropathy and spinal stenosis. Do you distinguish between those, and does it matter?
I think it does matter, because you might need an operation for your spinal stenosis, and that might make you better. Can you distinguish between it? Yeah, it can be challenging. I think sometimes if people have very prominent symptoms in their lower limbs and absolutely nothing in their upper limbs, that can suggest a spinal problem. But otherwise, you could have problems in the three lower dermatomes, L4, L5, S1, which is sort of numbness to the knees, bit of a loss of balance, loss of reflexes in the lower legs, and it can be really difficult. So, if somebody had those sort of symptoms and they had normal nerve conduction studies, so if they had loss of reflexes, loss of proprioception and balance, then you should be thinking spinal stenosis and doing a scan. If their nerve conduction studies are normal, if you've got both, then your nerve conduction studies are going to be abnormal. But yes, I think having an index of suspicion and knowing that spinal stenosis is out there is important, and doing a scan if needed. Yeah.
The results of treatment for spinal stenosis don't seem all that impressive.
Right.
To me, is that true? Is that your impression? Or
You're talking about in general or with amyloid?
I suppose in general, with in terms of surgical treatment.
I've got to say, I haven't sort of researched into that. Anecdotally, I've had a number of patients do quite well with spinal stenosis. I couldn't comment on how it is with amyloid. I suspect the majority of people who are getting operations for spinal stenosis, it's not considered. And often what they say is it's a combination of disc disease, ligamentum flavum, hypertrophy, osteophytes, etc. But yeah, I couldn't comment on the sort of stats behind that. Yeah.
How about electrical shocks? I get scattered all over my body, mostly in my organs and predominantly my kidneys. It's like a cattle prod. Just they're so fast and they make you yelp. So what is it with that? Because doctors look at me like I'm crazy. Especially, you go see a kidney doctor and he said there's nothing wrong with your kidneys.
So it's just sort of anywhere within the body for a
Mostly
brief time.
it happens anywhere in my body, but mostly in my organs, any of them. and predominantly my kidneys. Like I've had like a half a dozen this morning.
Right.
But it's like a cattle prod, just goes off, and some of them are very painful, but they're very quick.
I mean, it can be a little bit tricky for us to sort of define what's causing that sort of thing. I mean, I guess if somebody has, peripheral neuropathy and it involves some of the, the nerves and looking after the trunk, those sorts of things can happen. But, I don't think we fully understand where, some of these symptoms come from. I mean, I think it's important to, with these symptoms as well, it's a bit like sort of itch, to make sure people don't have things like, iron deficiency or bad kidney function and things like that. Medications aren't contributing. Sometimes I think on a practical level for that kind of thing, people can respond to some of the same medications that we use for neuropathic pain, which can sort of settle down some of those extra sensations by modulating the nerve transmission in the brain. But it can be hard to know where those sorts of things come from. Yeah, but it's you're not the first person to say something like that to me. Not specifically with amyloid, but that is a symptom that some people get. Yeah.
No one ever seems to mention cramps, but I just wondered, is it possible that this nerve thing has something to do with the muscle? I mean, that the muscles have got everyone just sort of raises their eyebrows when you have bad cramps, it's really horrible.
Oh, absolutely. So that's in the lower legs particularly. I mean, so look, lots of causes of cramps, obviously making sure that there's not a electrolyte disturbance or something like that. But I think cramps is definitely part of neuropathy. So I think it originates from the peripheral nerves, and it just happens to manifest in something that affects the muscles. So it was interesting when I worked in London, I did work in a muscle clinic as well, and they used to get referrals with cramps because it was the muscle, but they used to say, look, they're originating from the nerves. What you do about cramps? I mean, I think it's a hard treatment. I mean, some people would say quinine. I mean, actually in London they did use quinine, but there's a concern about it causing a heart problem. But I think you need to take quite a lot for it to be a high risk. I'm sort of saying this hoping that I'm not going to get corrected soon. You
can actually find quinine in tonic water. Apparently gin goes quite well with tonic water, and most of my patients after their third gin and tonic, they don't even care about the cramps anymore. Magnesium's very good as well. So there are all different formulations of magnesium. So I would say if you're someone, even with the electric shocks, it's probably just, it won't hurt you to take a couple of tablets of magnesium. Ask your pharmacist which is the best one. It's often, you often have to kiss a lot of frogs to find that sort of perfect thing. But I must admit, a lot of my patients, I say, look, have some tonic water, to wash down a couple of magnesium tablets. That's sort of the first thing. And then getting on some of the things that Duncan spoke about, like the amitriptyline, because or NZAPA, as it's often called, actually also helps you with your sleep, because of course if you've got muscle cramps and little electric shocks, it really disturbs your sleep as well. It's hard to get to sleep. So it's just trying to find what works for you. Some people say that amitriptyline is useless, and there was something else that really helped. So unfortunately, we've got a lot of different treatments for peripheral neuropathy, and the reason for that is none work in everyone absolutely.
I just want to say, with regard to the magnesium, those of you who have got gastrointestinal issues, especially with AL, be careful of how much magnesium you take, because you'll end up probably getting diarrhea or something. I found for me, exercise was the important part of getting rid of the cramps, and especially just calf raises and just little things like that. I think for me personally speaking, that exercise was the best thing. Not too much magnesium for sure.
One medication I didn't mention is for cramps specifically is carbamazepine, which is an anti-epilepsy medication, but it can cause drowsiness and things. So gabapentin is the other one, possibly more than the amitriptyline. But you're sort of balancing it with side effects and other things. So I had heard you needed to drink about 20 litres of tonic water a day to get as much as you get in quinine tablets. But don't know how that goes with the fluid
It's
restriction.
true, but it's that's a lot less fun than the gin tonics.
Yeah.
This is going to be our last question, I think. So because we've got lunch. Sorry.
Just a little comment about quinine. I used it for years as a GP. Very effective for cramps. We were told not to use it because it sometimes causes bone marrow depression. I think that was the reason. And I've never seen that, but it's a rare thing, but if it were to happen, it would be a bit of a disaster. And the other little comment is that a lot of the treatment that you may be on for amyloidosis will also cause cramp, particularly diuretics, which very commonly cause cramp. So it's not just the disease, it's also the treatment sometimes.
Jamie, I think you've been cooking since 4 a.m. I think so.
Yes, so thank you. Can we give a round of applause to Dr. Smyth, please?
Where do we do lunch?
Yes, so thank you. Can we give a round of applause to Dr. Smyth, please?